All right, thank you so much for having me, everyone, and good morning. My presentation is Health and Wealth, Exploring the Intersection of Health and the Economy. Thank you, Tanae, for that wonderful introduction, and thank you to the Tennessee Healthcare Campaign for inviting me to speak on today's session, Closing the Coverage Gap in Tennessee. As today mentioned, I'm the Associate Director of the Howard H. Baker Jr. Center for Public Policy at the University of Tennessee, Knoxville. So first, before I begin this discussion, I want to just acknowledge and put out there that health is independently important for its economic value. So my talk is going to center on the relationship between health and wealth, but I do want to say that and acknowledge that health is independently important from its economic value. And there is a value of health that is separate from its ability to contribute to economic growth at the micro and macro levels. Most of what I'm going to be discussing this morning a chapter that I co-authored with Dr. Matthew Harris, an economist and associate professor with the Boyd Center for Business and Economic Research. It's the fourth chapter in the 2020 Economic Report to the Governor for the state of Tennessee, and the chapter is entitled Public Health and Economic Wellbeing in Tennessee. If you're interested, I would encourage you, it's available online to read more about what I'm going to be presenting here today. So first, a few key points from as takeaways from the chapter. First, while the state has experienced strong economic growth for the last decade, ranking in the top 15 of states in terms of employment and overall economic output, this is pre-pandemic, far from its economic potential. And part of that failure to reach full economic potential.
Dr. Cahill, I'm going to stop you for just a moment. I believe we're having bandwidth issues.
In addition, access to health insurance is linked to improve.
Dr. Cahill?
Here.
Okay, can you hear me? Okay, so I believe we're having bandwidth issues, but we're going to give Dr. Cahill just another moment. Okay, so we're going to take a step back and we're going to regroup, and I'm hoping that we can move on to another panelist as we wait for Dr. Cahill to come back. Dr. Cahill, are you here with us?
I am. Apologies. Okay. Are you able to hear me?
I'm able to hear you now, and there's a suggestion to turn off your camera. That might help with bandwidth issues, and let's keep going and see how it works out.
Great.
Thank you.
So I'm going to, is it this better?
Yes, much better. Thank you.
Great. Wonderful. Okay. So, so in terms of the key points, the first is that Tennessee is far from reaching its economic potential. The second is that poor health is an economic problem for Tennessee. The third is that access to health insurance is linked to improved health outcomes. And the fourth point is that improving health across the state over the long term will lead to improved economic growth and prosperity for individuals and in distressed areas. Okay, so in terms of an overview of what I'm going to discuss, the first is the relationship between wealth and health. And so this is the idea that increases in wealth contribute to increases in health. The second is an emerging understanding of the relationship between health and wealth. That is that improvements in health actually lead to increases in wealth. So this is sort of that economic story. Next, I'm going to discuss about human capital and its role in economic growth. Then I'm going to discuss the economic cost of poor health to Tennessee. And finally, just briefly mention the relationship between health insurance and improvements in health. Okay, so in terms of the wealth-health connection, research has found a positive relationship between the wealth of a country and better health outcomes. This is probably something with which many of you are familiar. So the idea here is that increases in GDP per capita lead to investments in healthcare infrastructure, such as hospitals, investments in healthcare research, as well as more robust health insurance schemes. Secondly, increases in GDP per capita lead to investments and in routine public health initiatives, such as routine immunization, as well as safe drinking water, healthy food. And then next, that increases in GDP per capita lead to things that are social determinants of health, such as improved educational access, safe housing, and public safety and safe communities. And so this is a very robust relationship that has been explored for a really long time about at the country level, how increases in country level wealth have led to these improvements in health. Okay, research has also found, though, a positive relationship between income and better health outcomes for individuals. So, for instance, increases in income lead to more regular and routine care. So, having a normal primary care physician, for example, the ability to pay for necessary prescription drugs to treat ailments, as well as access to health insurance, most normally through an employer. In addition, increases in income are associated with more likelihood to exercise, to eat healthy, less likely to engage in negative health behaviors such as smoking, more likely to obtain educational attainment, more likely to be involved in one's community, so building up that social capital in one's community, and also less likely to experience high levels of stress. And so here we see that at the country level and at the individual level, there are benefits to increases in wealth and health. So what does this look like? So first, the greater one's income, the lower one's likelihood of disease and premature death. More specifically, at age 25, Americans in the highest income group can expect to live 6 more years than their poor counterparts. And conversely, poor adults are almost 5 times more likely to report being in fair or poor health and 3 times more likely to have activity limitations due to chronic conditions. So in terms of what this looks like in Tennessee, the relationship between wealth and health, here on the right, there is a graph. And so along the x-axis or the horizontal axis here is the percent of households with income below poverty in a particular county in Tennessee. And the y-axis or the vertical axis is years of potential life loss per 100,000. And so really what this is a graph of is the relationship between increases in poverty and premature death at the county level. And each of these green dots actually represents a county in Tennessee. And what you can clearly see from the graph is the strong and positive relationship between increases in poverty and premature death. In fact, communities in poverty do not live as long. 1% increase in household poverty at the county level is associated with 22.6 years of life lost per 10,000 individuals in the community. Okay, and I know that that's kind of a difficult number maybe to get your mind around, so I've transformed it into something that's maybe a little more accessible. So just 1 more day. So in fact, this finding means that every Tennessean has 1 day less to live for every 1% increase in poverty in his or her community. And so that's the effect on the individual of just living in a community that is impoverished. It's not about their own poverty, it's just living in a community that has poverty. It's 1 day less for every 1% increase. Okay, so now what about the reverse? The literature has well established the relationship between wealth and health, but what about health improving wealth? So what about the other direction? How does health affect wealth? Or in other terms, how does health affect economic growth and well-being? Okay, so economists are increasingly starting to recognize that health is actually a form of human capital. Human capital are intangible collective resources possessed by individuals and groups within a given population. So this idea of human capital was actually popularized by Gary Becker. He's a Nobel Prize winning economist who observes that, unlike bonds and stocks and, manufacturing facilities, humans actually had their own resources and capital that were intangible to them and were very similar to education. And so like education, economists are increasingly viewing health as a necessary component of human capital investment. And so perhaps even more so than education, better health is actually linked to greater productivity across occupational domains. And so human capital is is a way of thinking about the way to invest in economic growth. And so really what economists are finding is that this is a cycle. It's a virtuous cycle where wealth, increases in wealth improve health, and increases in health status can actually lead to increases in wealth. And they've come up with some mechanisms by which they think that this occurs. So the first is labor productivity. So healthy workers actually lose less time from work due to ill health. They are less likely to suffer from chronic absenteeism, and they're more likely to be productive when working. This is known as presenteeism. Secondly, economists note that, that health allows for population growth, for a stable and growing population in the labor force who are participating in the economy and paying taxes. Thirdly, economists note that in terms of education, poor health can inhibit the realization of the full benefit of education investments. And they note that this is predominantly the case with children who are in poor health, but it also can be the case with adults who are in poor health because they're less likely both to invest in education for themselves and to receive the full benefit of that education if they're in poor health. And then finally, financial stability. So longer prospective lifespans increase the incentive to save for retirement, generate higher levels of savings and wealth, and a healthy workforce can increase the incentives for business investment. And I think that this last point is a really important thing for Tennessee to consider. We hear this from economists and economic developers all the time, but it's really important to know that economic development requires a stable, engaged, and healthy workforce. So Tennessee has made remarkable investments in a form of human capital, education, with its Drive to 55 campaign, but it's made less investments in another form of human capital, which economists even argue may be more significant, which is its health of its workforce. So what are the costs of this to Tennessee in terms of economics? So poor health here, this is a graph on the right, and it's broken down on the horizontal axis by ages. So this is 18 to 24 is on the left and 65 to 69 age categories. And then along the vertical axis is poor health days in the last month. And so this is self-reported data. So in the green dots, you can see the US average, the national average, and the gray dots are for Tennessee. And what we see from this graph is between the ages of 45 and 49, Tennesseans begin to disproportionately report days with poor health. And by ages 50 and 54, they begin to disproportionately select out of the labor force. And I'm going to show you that in a minute. So here we have at 45, 49, they're disproportionately much higher than the national average, reporting that they're in poor health, and then they select out of the labor force. And so I'm going to show you what that looks like here. So labor force participation is actually a really key economic indicator that economists pay attention to, even more so in some cases than the unemployment rate. And labor force participation rate is the rate at which people who are of eligible age are actually involved in the labor force, meaning they're working or looking for work. So we can see here again, gray dots are Tennessee and green dots are the US average, that the age at which labor force participation in Tennessee falls relative to the national average, 50, is also the approximate age at which risk for failing health begins to increase. And so we see that individuals in this age category in Tennessee are reporting more poor health days, and then they're dropping out of the labor force at a faster rate than the national average. And this is a really big problem for Tennessee in terms of its economic growth. So from this, one thing that we noted in doing this research is one of the, around this time, what's also occurring is cost barriers. So, so cost barriers here are displayed, again, age categories along the bottom and proportion along the right in terms of who say the cost. This is the proportion of individuals in each age band who are a doctor during the last 12 months because of cost. And what you can see at 40 to 50 years in Tennessee, we also see that difference emerging where they're reporting difficulty in accessing care due to cost. So what are the economic costs of poor health in Tennessee? So first, compared to the US average, Tennesseans are more likely to smoke, less likely to exercise, and more likely to become obese. By the middle of their working lives, Tennesseans are more likely to have heart disease and or diabetes and are at greater risk for heart attacks. During this time, Tennesseans also face higher barriers to care on the basis of cost and other factors such as hospital closures. And by age 50, they are less likely to participate in the labor force and earn less money than the national average for their cohort when they do. This reduced income leads to substantial economic losses for the state, even in an era of strong economic growth. So what can we see in terms of the relationship between health and wealth, the potential relationship between health and wealth in the state of Tennessee? So here's a graph on that's primary care providers per 100,000 in the population along the bottom, and along the right, percentage change in unemployment. And so here we see the United States is the green dots, and the gray dots are Tennessee. And we can see that across Tennessee and the US, improved access to primary care is linked to stronger economic growth, meaning stronger increases in employment rates. And so that this relationship we show in our chapter is also related to improvements in heart disease, improvements in obesity levels, improvements in activity. Every single measure that we put in, we see that there's this positive and important relationship, significant relationship between improvements in health and improvements in wealth. Okay, so then thinking about what can be done, and also thinking about the mission of this particular organization, what's the relationship between increases in health insurance and increases in health? So in 2002, the Institute of Medicine made a report, and they found that after reviewing 130 studies, that the uninsured have poor health and shortened lives, and that gaining coverage would decrease their all-cause mortality. And so this 2002 report really provided the foundation for the idea that health insurance is not just about avoiding financial liabilities for unexpected health occurrences, but also is a way of actually improving the health of those who are able to access it. And this actually finding was supported in a 2017 article in the Annals of Internal Medicine, which found that recent research supported and strengthened the conclusion that health insurance reduces mortality. And so it's not just that health insurance reduces financial risk, it also improves health and reduces the likelihood of premature death. So what are some conclusions that we can take away for our discussion? First, Tennessee has a long history of poor health, but strong economic growth. While the state has taken important steps, there's still much more work to be done. Taking steps to improve the health of the population need to be taken with the recognition that health and the economy are connected and equally important, and that will be key to unlocking the state's potential. And finally, COVID-19 necessitates that Tennessee recognize and be innovative in developing policies to promote the health-wealth connection. So thank you so much for your time, and I look forward to hearing from the other panelists.